difficulty walking. We've already dealt with some of these things. Like, what did we already cover that's difficulty walking? What did we cover in the last module?
Scoliosis.
Parkinson's. Okay. Huntington's could lead into things like difficulty walking. We briefly covered stroke. We'll talk about stroke again in a little bit more in depth in this section as well. So, what we're going to talk about is the most important thing, the nervous system, right? Nerves control everything in your body. And in order for your body to work, you have to have that correlation between your nerves connecting your brain and your muscles. So the central nervous system, what makes up the central nervous system? Brain and spinal cord. What makes up the peripheral nervous system? Everything that branches off the spinal cord, right? So like our sciatic nerve and our ulnar nerve, radial nerve, peripheral nervous system. So the neurons are myelinated or unmyelinated. And myelin is the protective sheath around the nerve. So all of our nerves are protected. In fact, they say it takes like 10 millimeter mercury pressure to alter the function of a nerve. So that's like the weight of a dime. So if you have like different pressure on a nerve, they can stop that nerve from transmitting the signals the way it's supposed to. So neurons are myelinated or unmyelinated. In multiple sclerosis, we're dealing with the myelinated nerves. Okay, how many of you guys have seen the commercials for MS? Does anyone know anyone that has MS? What are MS type symptoms?
One of my neighbor's toes were really crooked and they were kind of lifted up and it hurt for her to walk.
Anything else? There's those commercials about MS where it shows like the lady and like one day she's got like barbed wire around her eyes and then the barbed wire goes away and then they've got like stuff on her wrist, and it's just because it affects like your entire system because it's affecting your nerves, and your nerves just gradually get eaten away. Who's that? He's the guy from the infomercials on TV. The Tommy Coppersleeve. Montel? Yeah. Montel has MS. Okay, so it's not just a disease for females. So multiple sclerosis usually affects people anywhere from 20 to 50 years old. And what is it? Chronic demyelination of the central nervous system. And this demyelination results in scarring of the nerves. So we've talked a little about like with the stomach, with post-op ileus and things like that. What happens when scarring tissue builds up? If scar tissue builds up in your intestines, will your intestines work the way they're supposed to? No. If scar tissue builds up in your knee, is your knee going to work the way it's supposed to? What happens when scar tissue builds up on your nerves? Are your nerves going to work the way they're supposed to? No, absolutely not. Okay? So there's 4 different types. There's remitting and relapsing, multiple sclerosis, and this is where it comes and goes. Multiple sclerosis is really hard to diagnose too, like in the professional setting, because these patients are coming in and they're telling you all these weird symptoms, and sometimes they're there and sometimes they're not, and then they come back. So what are you thinking? What do you think of the patients? Yeah, she's either drinking or crazy, right? So wet brain maybe, primary progressive, secondary progressive relapsing. We'll go over those in the chart in a second. The causes, it could be autoimmune, it could be from a prior virus infection, it could be genetic or environmental. They say that the further away you live from the equator, there's more instances of multiple sclerosis. Isn't that odd? So like, if you're closer to the equator, there's lesser instances, and the further away you are, there's more instances of multiple sclerosis. Family history, 15% of multiple sclerosis patients have a family member with MS. Identical twins have a 30% chance of getting MS. So is it completely genetic? No, but there's a genetic base to it somehow, right? Does happen to females greater than males. The signs and symptoms, this is where it's weird because they vary due to which nerves are affected. And you need to have 2 separate episodes at different locations to help diagnose. So that's key. So you have to have 2 separate episodes at different locations in order to diagnose MS. That kind of sounds like it could be like a case study, right? Like a patient comes in with one thing, and then they're better, and the patient comes in with something else, and then they get better, and then you're like, wait a second. So visual changes could be unilateral and acute. Could affect like the cranial nerve demyelination, like optic neuritis. Could affect their balance, their memory, weakness, fatigue, spasticity, bladder dysfunction. They could have tremors, unsteady gait. And again, with testing, it's very, very hard to diagnose. Like, what are you pretty much going to have to diagnose this patient with? Like, you've ruled out 7 other things. You know, you've ruled everything else out, and then it's usually multiple sclerosis. Everyone that I know that's been diagnosed with multiple sclerosis, it took them like several months to get the correct diagnosis. And at first it's like they have allergies, and then they have, you know, all like deficiencies, vitamin deficiencies. They're looking at food allergies. They're doing all these things. Then finally it's MS. They can do an MRI because the demyelinated lesions will leave white matter, or the sclerotic plaques, these gliosis, are diagnostic. You can see those in MRI. They could do a lumbar puncture. So, and they're going to look for these specific antibodies where these oligoclonal bands, and they're present in 90% of MS patients. So this IgG, 90%. So I would look for that in the test, right? In the case study. Mm-hmm. They could also do these nerve conduction tests. How many people have ever had a nerve conduction test? Yeah, nerve conduction tests are painful. And what they do is they put a needle in one end of the nerve, and they put a needle at the other end of the nerve, and they send an electrical impulse down the nerve.
It's painful?
It's very painful. Yeah, very painful. And what they're doing is they're sending how fast that impulse travels from one end to the other, and it's very, very, very painful. Let's check out this little video here. Weren't we just on YouTube?
Multiple sclerosis, MS, is a disease that affects the central nervous system, the CNS, which consists of the brain, spinal cord, and optic nerves. Everything we do, whether it's taking a step, solving a problem, or simply breathing, relies on the proper functioning of the CNS. To understand how MS may impact the CNS, we must explore the disease at the cellular level. In the brain, millions of nerve cells called neurons continually send and receive signals. Each signal is a minute but necessary part of intricate CNS orchestrations that culminate in the actions, sensations, thoughts, and emotions that comprise the human experience. Normally, the path over which a nerve signal travels is protected by a type of insulation called the myelin sheath. This insulation is essential for nerve signals to reach their target. In MS, the myelin sheath is eroded, and the underlying wire-like nerve fiber is also damaged. This leads to a breakdown in the ability of the nerve cells to transmit signals. It is believed that the loss of myelin is the result of mistaken attacks by immune cells. Immune cells protect the body against foreign substances, such as bacteria and viruses. But in MS, something goes awry. Immune cells infiltrate the brain and spinal cord, seek out the myelin, and attack. As ongoing inflammation and tissue damage occurs, nerve signals are disrupted. This causes unpredictable symptoms that can range from numbness or tingling to blindness and paralysis. These losses may be temporary or permanent.
All right, so what is our immune system attacking? The myelin sheath, right? So, the different types of multiple sclerosis is based on how frequent the symptoms show up. So remitting relapsing, which is what 90% of patients start with, is it comes and goes. So they have an episode and then they're completely fine. And then they have another episode and they're completely fine. And then eventually, as it progresses, they're going to have an episode where it doesn't completely go away, and then it gets worse, then it gets better, but not completely. And that's relapsing and remitting MS. The primary progressive MS just continually gets worse. They might plateau where like they don't have any more new symptoms, or maybe their balance gets to a certain point where they can walk to a certain level, but then they're fine. And then all of a sudden, like it just starts to get worse again, and they're having a harder and harder time either seeing or walking or moving. Secondary progressive and progressive relapsing are the odd ones, because the progressive relapsing is it's relapsing, but every time the symptoms show up, they're worse. So they might go away, and then when they come back, they're never fully healed and recovered in between. So this is why it's hard to diagnose MS, because they have symptoms, they don't have symptoms. They have symptoms, they don't have symptoms. They have different symptoms than they had here, but then they're different, and then they're gone, and then they're back, and they're all over the place. So remember how I said in the beginning of the class that when you start diagnosing yourself with all these diseases, we
No,
go
I
over?
really think I have this.
Well, this one I have.
I really do.
So central brain nervous system, multiple sclerosis, the sheath, which is a protective membrane is destroyed with inflammation and scarring. Once it's scarred, it never really works quite the way it should. Some pictures of that. Here's multiple sclerosis and an MRI. And these are those, see the whitening? And these are those plaques. And these plaques are caused by MS. So if it's like this in their brain, what else did it say that they could have a hard time with? Like memory, decision making, which kind of sounds like some of the other things that we just studied, right? So these IGC, or these oligoclonal bands, are present in where? Where do we find these?
Lumbar.
Like a lumbar puncture or a spinal tap, okay? ALS. ALS is another progressive neurological disorder, and ALS is commonly referred to as Lou Gehrig's disease. Does anyone here know who Lou Gehrig was?
Baseball player.
Baseball player for the...
I don't know, but my patient has this.
Yeah, ALS is Lou Gehrig's disease from, he was a Yankee. So he was an amazing baseball player, and he was the first one that really started to have these ALS-like symptoms, but now like historians even doubt that he had amyotrophic lateral sclerosis, so it might be misnamed. But what this is atrophy of upper and lower motor neurons. Again, this is idiopathic, usually males greater than females. So what's MS?
Females.
Females greater than males. This age is 40 to 60. What was the age for MS? 20 to 50. Okay, so this is maybe a little bit older. This is genetic, possibly from an excess of glutamate. Signs and symptoms are diminished muscle strength, weakness and spasms, difficulty in speech, fatigue. They could have spastic and flaccid paralysis, depending on whether it's an upper motor neuron or lower motor neuron lesion. They're more likely to get respiratory infections. No intellectual or sensory impact. What does that mean?
We think the same.
Yeah. So if you ask them questions, their brain is completely functioning, right? This isn't any dementia or delirium or anything like that. So this just affects the progressive wearing down of the motor neurons in the disease. We could test Lou Gehrig's disease with an MRI. They could do the nerve and muscle conduction tests. They could look for this increased glutamate level. And the treatment for this is Riley-Tech. That'll extend the time, but it doesn't cure it, okay? Most people with AL...
What was the treatment for the
Do you have
last
this
one?
also?
No, I
Oh.
have the other one.
Okay.
What's the treatment for the other one?
With MS, a lot of, like, there's all kinds of experimental drugs. We have a student, she's got MS, so I'm gonna ask her what she's on.
I don't know, Montel seems to be doing really good. So.
Yeah, and he does the tiny copper sleeves though. So Montel's using those. And he also does doesn't he send like a blender or like a juicing blender? So maybe from juicing and whatever Montel's cured. I don't, like, with,
I gotta meet.
yeah, meet Montel. They're gonna have to do like a lot of anti-inflammatories and things like that with MS. But I'll check and see what she's using.
Okay.
So
Is it curable?
MS isn't curable. They try to control it and they try to slow the progress, but it's not curable.
It's okay.
What is spastic and flaccid paralysis?
Spastic paralysis is where it's tight. It's like a tight in muscle contraction moving. Flaccid is where it's just weak and loose. So flaccid is like no muscle tone, and spastic is where like it's contracted and it's tight. Oh my gosh, just 8 minutes. We're not going to watch this whole thing, but.
Watching a love story?
My husband Tom was diagnosed with Lou Gehrig's disease in 1996 and he was 36 years old. He had just started his career as a plastic surgeon barely 2 years before that. He and I had been together for 10 years prior and divorced for 4 years. One of the things that had taken us apart was the fact that we had went for 10 years before that when we were married, I could not get pregnant. And I was labeled infertile and there was no chance of me having children. So that was one of the prime factors that broke us apart. We had remained friends through our divorce. And as the symptoms started before the diagnosis, Tom and I became closer. And once diagnosis happened, we realized that life was too short and we had gotten back together so we could stick it out together and watch where ALS was going to bring us. When Tom was in medical school, he always said ALS is the worst disease, and he referred to the disease as the beast. And he wanted to be DNR, do not resuscitate, once the respiratory was affected. He decided to go skiing and sailing, and he did a lot of things one last time. And after he completed all these journeys that he wanted to take, we moved to Barnard, Vermont, and he asked me to marry him again. And then one day, I missed my period, and I couldn't even imagine that I had been pregnant.
That's the worst ALS video. I'm sure it's got a wonderful ending, except for him. So, ALS progressively gets worse. What happens with ALS a lot of times is it's going to affect their ability to breathe and their ability to swallow. So sometimes these people end up choking to death, or they're going to end up not being able to breathe because it's going to affect those muscles. So,
what's the difference between MS and ALS?
Age is different, cause is different, and ALS is progressive. So they're going to have symptoms that are progressively worse. And ALS usually affects the extremities first, then works its way in. So they're going to have problems with like their arms and legs and things like that before it gets into like their ability to swallow or peristalsis in the stomach and things like that. So ALS is the muscles are going to start to atrophy. So they're going to have less muscle function, they're going to have decreased health of the nerves. The body's just not able to work the way it's supposed to. Okay, so what would be the difference in case studies between ALS and MS? ALS is more males, MS is more females. MS is that relapsing where they have the symptoms and it goes. So with MS, it could be like they're blinded and then their vision comes back and then they have a hard time walking and then that gets better. And then next time they have walking and vision problems. So remember, you have to have 2 episodes of 2 different areas for MS. ALS is just progressive. So ALS, again, is another difficult thing to diagnose because it's just a progressive wearing away. Myasthenia gravis this is a chronic autoimmune disease, and this is loss of acetylcholine receptors at the neuromuscular junction of voluntary muscles. Okay, so again, this is autoimmune. This happens in females under the age of 40 or men over the age of 60. So if it's younger, if you're female, you're going to get it younger. If you're male, you're going to get it older. So this is going to be muscle weakness and fatigability. Usually it happens in the eyes first with ptosis or diplopia. Ptosis is like the droopy eye. What's that? I don't know. Diplopia?
No,
Oh, AI is autoimmune. Al causes it. Al causes a lot of things. This is a progressive muscle weakness with activity. So myasthenia gravis is, as the more you use the muscle, the worse it's going to respond. So it's going to be worse when you're under stress, it's going to be worse when you're out in the heat, or it's going to be worse with physical exercise. So this is going to be a case study that's going to be like someone who's doing fine, but like it's a younger girl and she goes for a jog. And after the jog, she starts to get the signs and symptoms of like eyes droopy, legs aren't working the way they're supposed to, things like that. But then as she cools down, everything comes back to normal. Or if they're under stress, they're going to have like the eyes drooping. Or if they're tired, it can happen. Do you ever have that where you're like so tired that like you get that twitch in your eye?
Yeah.
That's not this. This is totally different, all right? So yeah, the test for this, they're going to do an Endophonium Test, and they're going to see if muscles can regain their strength for your period. They can do an EMG, or again, these repetitive nerve stimulations to see how your muscles and nerves work while they're tired. There's no cure. The treatment focuses on the symptoms. So patients can lead normal or near normal lives with medication. And the medication is like these anticholinergic medication. that's going to help with their muscle receptors. So myasthenia gravis is, here's like droopy eye.
I have that.
You have that too?
No, that's me.
Oh, you have myasthenia
I
gravis?
have MS.
You have MS,
She
okay.
has MS.
Okay.
No, they're seriously, because last week I was out because of pink eye, and then I had, what's it called, some other infection, whatever. And then they were like, why did you come back? Because we think that it's this.
Really?
Because my eye's like not going back to where it should be.
Uh-oh. So let us know.
And there's no cure.
There's no cure for it. But you can live a normal or near normal life as long as you live in a stress-free environment that you don't exercise. So you have to move to like an island somewhere and not worry. So what happens with myasthenia gravis is the immune system makes these antibodies that damage or block the acetylcholine receptors. So this prevents the acetylcholine from binding to the damaged receptors and acting on the muscle. So they're going to have reduced muscle contractions, and they're going to have easier, they're going to get weaker, and they're going to have fatigue. So what happens with myasthenia gravis once they rest, though? It gets better and comes back to normal. What happens with ALS once they rest? It's the same. Yeah, it just progressively gets worse. What happens with MS once they rest? It depends on if you're an episode or not, right? If you're during one of your recurring episodes, then the treatments are there. Okay, so Bell's palsy. Bell's palsy, we talked about trigeminal neuralgia, or tic del roux with cranial nerve 5. Bell's palsy is cranial nerve 7. So what were the signs and symptoms with trigeminal neuralgia?
Burning, shock.
Burning. One side or both sides of the face?
One side.
One side shock-like, right? Did it affect the muscles and mastication a little bit? Okay? So weakness and paralysis on one side of the face. This is usually between the ages of 15 and 60, and this is cranial nerve 7, Bell's palsy, the facial nerve. This is usually after like an upper respiratory infection, like a viral infection, or it could be like from herpes simplex or Epstein-Barr. In Bell's palsy, when people wake up, it's sudden onset, so they wake up and their face is paralyzed. So what do you think you had? A stroke. Yep. So they're just no feeling, like, you guys ever been to the dentist, had like the
I was
Novocaine?
just thinking about
Yeah, and like you can't talk, and like you're drooled out of one side of your mouth and everything. That's Bell's palsy, like times 10. Like it's horrible. They can't close their eye. They can't blink. So they have to like put a little patch over their eye to help them sleep at night. They're drooling on one side. Like it's horrible. And Bell's palsy will go away on its own, and it's slow. Like if it's bad enough, it's very slow. It's not like you're there, it's numb and like you just slap it around a little bit and it comes right back. Like once that nerve's been affected, it's slow to heal. Your nerves heal super slow. So it's sudden onset. One side paralysis, it's only in the face though. Like with a stroke, will you have paralysis just in your face or you have it somewhere else?
In your arms.
So strokes can be one-sided, right? So it can be right side, right arm, right leg, right side of face. Stroke can affect your speech, like Broca's and Wernicke's. This isn't anything like that. It's just your facial muscles, okay? So what they do whenever you have someone with Bell's palsy, what's the first thing you want to rule out?
the stroke.
Yeah, they have a stroke, because stroke's important to rule out because your success in overcoming your stroke is based on how fast you can treat it, right? So the faster you can restore the blood flow to the brain, then the less the symptoms are going to be after the stroke. Like once you rule out, hey, it's not a stroke, then it's Bell's palsy. And what do you tell the patient? It'll go away eventually.
And it comes back like
It could come
comes and
back.
goes?
Yeah. So well, it's not like MS where it's repetitive or cyclic. They could get it again once they've had it, but not on a regular interval basis or anything like that. So this could actually lead to eye damage too because of lack of lubrication because they can't blink. So if you can't blink your eye and your eye's stuck open the whole time, so they're always, the treatment is this, is like they're using wetting drops, they're trying to use a patch, so nothing gets in their eye at night, they're drooling on one side of their mouth, like they're real fun to be around. So test it, rule out stroke. Treatment is, this is often short-lived. They can do anti-inflammatories or like antiviral medication. Most people have full recovery within weeks or months. But if you woke up with Bell's palsy and they tell you like, hey, you're gonna get better in a couple weeks or a couple months, that's not fun. All right, not fun at all. So Bell's palsy versus stroke, So Bell's palsy is only on the face, right? Stroke could be somewhere else. Stroke typically affects the lower portion of the face. So if you could wrinkle your brows, then it's, if you can, then it's a stroke. If you can't, then it's Bell's palsy. Okay? Or you can wrinkle your brow on one side with Bell's palsy. If you can close your eyes tightly, if you can, might be a stroke. If you can't, it's Bell's palsy. Because Bell's palsy is just like complete paralysis. Like it's just out. So 7th cranial nerve has a very similar outline pattern as cranial nerve 5, right, with trigeminal neuralgia. Just a difference in symptoms. So this is typical with Bell's palsy. It's the drooping eyelid. It's the drooping face. They have this, the frown, that their smile turns down on one side. Looks just like the guy that just left the dentist, right? You can like wisdom teeth pulled, you're gonna look just like this. But you're gonna feel like this for weeks or months, not just a couple hours. They could have some little bit of twitching in their muscles. When you pulled up on the computer, you're gonna be able to see the progression of this guy as he went through like a whole month of recovery from getting his eyes. See how his eyes open here and closed? There, it looks better once you pull it up on your computer screen. All right, Parkinson's disease. Did we already go over Parkinson's? You guys pretty familiar with Parkinson's? Dopamine,
Why is it repeated?
because of difficulty walking. So it's just review. Later stages dementia, Parkinson's. Midsection of brain. What was the test question on Parkinson's?
I think it was
Football player.
Like cut open his.
Oh wait, that was,
It
yeah.
was asking which and or.
Oh yeah, what is he deficient in? And the answer was dopamine.
Yeah.
Right? Okay. So cut section of midbrain, substantia nigra, normal, affected. Tennis elbow. So tennis elbow is the lateral epicondylitis. Where's your lateral side? Which one's medial and which one's lateral? Outside here. Can you get tennis elbow and never play tennis?
Yeah.
Yes. Yeah, you don't have to be a tennis player to have it. So if you hear of a tennis player, like if the case study is a tennis player, has elbow pain, pretty good, but that's not what we're going to do. All right? So tennis elbow is on the outer. It's a lateral epicondylitis. What causes it? Why do they say why do they call it tennis elbow? Repetitive, right? It's a repetitive motion.
So